Hi, this is Tyler Foster, and welcome to the Pharmacology section on toxicity and side effects. This section is not the bread and butter of our pharmacology content. However, there will be some test questions related to toxicities on test day. The mechanism of action is rarely asked, so it's not that important, but you do need to memorize the lists in this section, which will be very important since these do appear on step 1 every now and then. I'll go ahead and cover the most high-yield topics here now. We will first start off with an acetaminophen overdose. Acetaminophen can be oxidized into NAPQI, N-acetyl P-benzoquinonamine, so NAPQI. Now this is a metabolite that is toxic to our liver. So this is going to be toxic to our liver. This NAPQI can be further conjugated with glutathione to form a non-toxic byproduct, but in cases of acetaminophen overdose, this glutathione is going to be depleted. N-acetylcysteine is going to come into the rescue. N-acetylcysteine is a metabolic precursor for our glutathione and therefore can be administered to restore our glutathione levels and prevent NAPQI-induced hepatotoxicity. Interestingly, this N-acetylcysteine can also be used as a mucolytic in diseases such as cystic fibrosis. Like I said earlier, the exact mechanism is not going to be as important for test day, but it may be useful to remember why a certain treatment is used. So what's the take-home message? Well, just remember, in cases of acetaminophen poisoning, N-acetylcysteine is going to be used to replenish our glutathione levels, which is a protective agent. Before we jump into this slide, let's do a little review. Beta-1 receptors are going to be found on the heart, and when they're stimulated, what is going to happen? Well, when stimulated, beta-1 receptors are going to increase our heart rate and also increase our contractility. So those are the heart symptoms that you're going to see with a beta-1 stimulation. Now with that said, what symptoms will a patient who overdosed on a beta blocker have? What heart symptoms will they have? Well, hopefully you're thinking since they're blocking the beta receptor, they're going to have a low heart rate or bradycardia and also low blood pressure or hypotension. So if a patient comes into the emergency room for a beta blocker overdose, how are we going to treat them? Well, to answer this, we need to recall what we learned from the pharmacology autonomic section. What kind of G protein is our beta-1 receptor? Yeah, that's right. Beta-1 receptors are of the G sub S category of G proteins, so they go on to activate or stimulate our adenylyl cyclase, which is going to convert our ATP into our cyclic AMP. So if you block the beta-1 receptor, you're going to have a decrease in cyclic AMP levels within the cells. Now this is where glucagon comes in. Glucagon is going to treat a beta blocker overdose because it's going to increase cyclic AMP levels within the cells, but via a different route. So it's going to bypass this blocked adrenergic system. So it's going to increase cyclic AMP levels within the cell just via a different route. Let's go ahead and clear that off. And now we can talk about digitalis, another heart drug toxicity, you could think of it. So to treat digitalis poisoning, what two things need to be done? There's an obvious answer and a not so obvious answer. First, we need to stop giving digitalis, but second and more importantly, we need to give anti-digitalis Fab fragments. So as a side note, note from the immunology section, you're going to see that digitalis is one of the very few drugs that has a monoclonal antibody as a therapeutic antidote. So here's a monoclonal antibody, for example. So since we're talking about digitalis, let's go ahead and do some cardiology review. Now, what is the mechanism of action for our digitalis drug? Well, our digitalis is a cardiac glycoside that's going to inhibit the sodium-potassium ATPase, which leads to an inhibition of the sodium-calcium exchanger. Now, this is going to increase our intracellular calcium levels, which is going to lead to positive inotropy, and then also it's going to lead to increased contractility. So that is how digitalis works, and the treatment is going to be in the form of a monoclonal antibody, an anti-digitalis fragment. Here's a fun toxicity to talk about. In methanol and ethylene glycol poisoning, these actual compounds themselves are not as toxic as the metabolites that they produce. So jumping back to biochemistry, we need to resurrect the enzyme alcohol dehydrogenase. Now this enzyme, alcohol dehydrogenase, turns our methanol and ethylene glycol into its toxic metabolites, which then go on and harm our body. However, this enzyme also converts ethanol, or alcohol, into our acetaldehyde. Now this is a byproduct that causes the hangover effect after a long night of drinking. Needless to say, many of you will experience an acetaldehyde overload after taking the USMLE. A surprising and yet effective treatment for the treatment of methanol and ethylene glycol toxicity is going to be giving alcohol, which is going to compete for the binding on our enzyme alcohol dehydrogenase. So let's go ahead and look at that. This is going to slow down the enzyme converting these toxic components into their metabolites. Now, although this is interesting theoretically, the thought of doctors making patients hammered isn't looked too highly upon. So experts set out to find a different or better solution. And what did they come up with instead? Well, they found that fomepizole is going to be a better treatment, a competitive inhibitor of the enzyme alcohol dehydrogenase. Boards like testing your knowledge on this concept, so remember that alcohol or fomepizole both work as the answer for our methanol and ethylene glycol toxicity. I doubt that they would give both answer options, but be aware that both of these are acceptable answers. We should also talk about warfarin because it's so common in the clinic and you should be aware of how to treat overdoses. So here's a quick hematology lesson. What are the vitamin K dependent clotting factors? Hopefully you're thinking 2, 7, 9, and 10. Now, these certain clotting factors need to be activated via a process of gamma carboxylation to therefore become active. So here we have our inactive clotting factors, the 2, 7, 9, and 10. They're going to undergo gamma carboxylation and thus become active. These can go on then to work in the clotting cascade and stop bleeding. Now, if they're not activated, then they're not going to be useful. Notice how we need a reduced form of vitamin K for this gamma carboxylation process to occur. Once this vitamin K is used, it's going to be then oxidized vitamin K. So now that we've used our reduced form of vitamin K, our gamma carboxylation can no longer occur. So thus we need to recycle our oxidized version so gamma carboxylation can occur again. To recycle our vitamin K, we need to introduce an enzyme called vitamin K epoxide reductase. So this is going to convert an unusable form of vitamin K back into a usable form so we can keep on with the gamma carboxylation, therefore spitting out more active clotting factors, which can then go on to stop bleeding. Warfarin is actually going to inhibit the process of vitamin K recycling. It's going to prevent gamma carboxylation, so therefore we cannot keep converting our inactive factors into active factors. So then gamma carboxylation stops. So if you don't have these activated factors, you'll bleed. So let's go ahead and think about a question now. You have a patient that comes in and they were prescribed too high of a dose of warfarin, and now they're bleeding too much. So in other words, they have acute blood loss due to a warfarin overdose. How are you going to treat this patient? Well, in cases of warfarin overdose, you need to give either fresh frozen plasma for the immediate reversal of anticoagulation, while vitamin K is going to be given for more long-term reversal. Giving this fresh frozen plasma, FFP, will provide the immediate clotting factors 2, 7, 9, and 10 in the active form. And then for more of a long-term treatment, our vitamin K is given. So vitamin K allows the enzyme gamma-glutamyl carboxylase, the one that actually provides the gamma carboxylation, and it's going to allow it to transfer carboxyl groups onto the vitamin K dependent factors. If you don't have vitamin K available, you won't activate your vitamin K dependent clotting factors, which are the 2, 7, 9, and 10. How can this all appear on a board question? Let's say you have an 87-year-old female on warfarin for AFib. Very common situation you'll see in the clinic. She comes in with altered mental status after a fall. Being the astute physician that you are, you order a stat CT of the head, which shows a large subdural hematoma. Her INR, you find, is going to be 6.3. And usually the target INR is 2 to 3 on warfarin. So what do you immediately want to do to treat the coagulopathy caused by our increased warfarin levels? Well, let's say you've narrowed down the answer options to both vitamin K or fresh frozen plasma, two options that can be used to treat a warfarin overdose. Which one will you give for the 87 with altered mental status due to a large subdural hematoma with this INR that's really high? Well, you'd want to give fresh frozen plasma. And why is that? Well, vitamin K is the wrong answer because it doesn't immediately reverse the coagulopathy. Remember, our fresh frozen plasma contained our active clotting factors, and this patient has a cranial bleed, so you do not want to delay in this scenario. Let's go ahead and clear this off. And since we're on the topic of anticoagulation, we should also cover a heparin overdose. Now you can do two things. You can simply remember that protamine sulfate is going to be given in scenarios of a heparin overdose. Or you could ask yourself, why? So let's go ahead and explain why. We have the clotting cascade. Remember I said these are some factors in the clotting cascade. The clotting cascade forms a clot. Now we have a factor within the clotting cascade, factor 2A. Factor 2A is also called thrombin. Now, our clotting cascade, factor 2A, is going to help form a clot. We also have a molecule of antithrombin 3. So this molecule, antithrombin 3, well, let's look at the name. What do you suspect antithrombin 3 to do? Hopefully you're thinking that it works against thrombin, or it's going to inhibit thrombin. And like I said, thrombin is used in the clotting cascade. So if you inhibit thrombin, you're not going to be able to form a clot, and therefore you're going to bleed. So this is where heparin comes into the picture. A molecule of heparin is going to go and actually activate our antithrombin 3. When we activate our antithrombin 3, we're going to bleed more. So that's why heparin is used as an anticoagulant. Now let's say you have a heparin overdose. You have too much heparin in the system. You can give the protamine sulfate. So we have a molecule of heparin here, and our protamine sulfate is going to bind to that molecule of heparin. And this forms a stable ion pair that does not have anticoagulant properties. So when this protamine sulfate is bound, heparin can therefore not go on to activate more antithrombin 3, thereby reversing the risk of bleeding. So clinically, you're going to follow the activated partial thromboplastin time when regards to heparin, and then like we already kind of discussed a little bit up here, our warfarin is usually followed by INR. So this is going to be our activated partial thromboplastin time, and warfarin is usually followed by the INR. There are many other toxin-antidote relationships that are useful to know, and my recommendation is to make flashcards on these. These can turn out to be easy points for test day, so please do not neglect them. Let's now try our hand at a practice question. A 4-month-old infant shows up to the ER with cyanosis. An arterial blood sample is chocolate colored. What is the likely diagnosis, and how are you going to treat this patient? Well, a blue baby with brown-colored arterial blood probably has methemoglobinemia, a possible metabolic disorder in which there is a high level of oxidized hemoglobin with ferric iron, Fe3+, rather than the normal ferrous iron, or Fe2+. Our oxidized hemoglobin has a lower affinity for oxygen. Now, treatment options include giving methylene blue, which is going to increase the activity of methemoglobin reductase. So it's going to increase our levels of methemoglobin reductase, or you could try giving vitamin C, which is going to actually directly convert our ferric iron, so our Fe3+, into our normal usable iron, which is Fe2+. So either way, methylene blue, we're going to stimulate or ramp up our methemoglobin reductase, which is hopefully going to convert our Fe3+ into our Fe2+, or vitamin C is thought to directly convert our ferric iron into our ferrous, or normal desirable iron. So this concludes our discussion on the specific antidotes. Here's a list of commonly tested antidotes. I tried to pull aside the ones that I think are the highest yield for the USMLE, but make sure you're familiar with all of these for test day. My recommendation again is to make flashcards for the antidotes and quiz yourself every so often. Eventually these should stick and will become easy points for test day.